Welcome, everyone, to our NMHI public lecture on COVID and the brain. My name is Ian Winship, and I'm a neuroscientist here at the University of Alberta, and I'm also Deputy Director of the Neuroscience and Mental Health Institute, or NMHI, as we call it. I'd like to start today with an acknowledgement of traditional territory. The University of Alberta acknowledges that we are located on Treaty 6 territory and respects the histories, language, and cultures of First Nation, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. So thank you all for joining us tonight. I think the popularity of this event, we already have 400 here and well over 1,000 were registered, really attests to the fact that COVID-19 remains top of mind for most of us. The global COVID-19 pandemic has truly been a generational event. Already over 70 million people worldwide have been infected, and tragically 1.5 million people have died. That only tells part of the story, as some people estimate that 50 to 80% of the world's population may eventually be infected. Healthcare systems have struggled and in some cases tragically collapsed under the weight of so very many critically ill patients. And this has prompted drastic action by governments. Our social structures have been dramatically changed in an effort to keep us safe through isolation protocols. This totally alters the way we interact with our family and our friends and the way we conduct our work. Entire economies have been shut down to facilitate the physical distancing that keeps us safe, but this too comes with a personal and societal cost. Science has moved very fast in response to the pandemic, developing and improving treatments for patients every single day. And indeed, in just slightly over 1 year, we have identified a novel virus. We have determined the entire genetic code for the virus, determined the parts of the genetic code for proteins that can be used to identify the virus, then created a vaccine that teaches our body to produce those proteins so we can mount an immune response against it and eradicate the virus. That's in 1 year, and that's truly impressive. But as much as we've learned and achieved, there's still so much to do. And in the NMHI, we are home to scientists and clinicians dedicated to the discovery and application of knowledge to improve health. And we're also dedicated to sharing knowledge with the public because we believe that this knowledge is power in efforts to maintain our well-being. So today we want to share what we've learned about how COVID can specifically attack our nervous system, how the drastic changes in our social structures and support networks can impact our mental health, and what the science says we can do to preserve our well-being. We have 4 truly outstanding clinician scientists from the NMHI here to present today. They're researchers, they're teachers, and they're physicians, and they're going to offer their own unique perspective about what the science tells us about COVID and the brain. So with that said, it's time to get started. So first up, we have Dr. Jennifer Mccomb. Dr. Mccomb is an associate clinical professor of neurology here at the University of Alberta. She also holds a master's degree in public health from Johns Hopkins University in Baltimore, where she studied the neurological complications associated with HIV infection. She is co-chair of the Encephalitis working group at the University of Alberta Hospital, which works to improve diagnosis and treatment for individuals with autoimmune encephalitis. And she's also a dedicated teacher, having won a number of local and national teaching awards. And tonight, she's going to teach us about COVID and the brain, what we know and what we have yet to discover.
Excellent. Well, thanks, Ian, and thank you for having me speak today. My talk is entitled COVID-19 and the Brain, What We Know and What We Have Yet to Discover. So what are we going to get through the next 15 minutes? Well, first, I'm going to talk about what we might have anticipated. There's some viruses that came before COVID-19 that taught us a little bit about what we might have expected, and so discuss that a little bit. I'll talk about what we have seen, so the neurologic symptoms that we are currently seeing in patients with COVID-19, and then talk a little bit about what we have yet to determine, so things that are emerging that make us a little bit worried and what we might expect for our future. So what might we have expected? Well, prior to COVID-19, there was actually a couple of viruses that emerged that were quite similar to COVID. So these are SARS and MERS. And interestingly, despite the fact that these were much less common, there were neurologic complications reported with both of these. Of course, this didn't get the same press as it is with COVID because so many fewer patients. were infected by these viruses, but we do know that there were neurologic complications. With SARS, in fact, we were able to show that there was virus in the brains of some of the people who died of the virus, as well as inflammation associated with it. With MERS, there was psychiatric symptoms, seizures, stroke, Guillain-Barré syndrome, which is an inflammatory syndrome that affects the nerves and can result in paralysis. So if we look at the, so like Ian said, we were able to already get the genetic code of the viruses. We can see that there was a lot of similarity between these viruses. And so you can expect that given that we had neurologic symptoms with these, that we might anticipate in COVID. So there's this study that was done by an English group. It was really interesting. And so this is a little bit earlier on in the course of the infection. So this was done back in May. And what they did is this kind of clever thing where they looked at the number of neurologic complications that they saw with MERS. And then they used those numbers to extrapolate and try to figure out how many neurologic complications we should be seeing with COVID. And based on the numbers back then, when at that time there was only about 4.8 million infections worldwide, we could see that approximately 17,000 people potentially could or should have neurologic symptoms with that. Well, of course, now with greater than 70 million people affected worldwide, if you use the same model and statistics and math, then we would predict that approximately 250,000 people worldwide might have neurologic complications. And so we can predict that potentially we might see a lot. So what are we in fact seeing? Is this kind of adding up? Are we seeing these? And in fact, we are. There's some more common and thankfully less concerning neurologic complications that we're seeing. And of course, the scarier ones that we are more worried about. So some of the ones that we see very commonly are things like headaches, anosmia, or a lack of sense of smell, which is one of the symptoms that is talked a lot about in the media and really has alerted us to the fact that we might have neurologic complications. Myalgias or muscle aches, as well as fatigue. In terms of more concerning symptoms, which thankfully are more rare, there are a number of things that have been reported. So encephalitis, or actually viral infection of the brain. Stroke is more common in people infected with COVID. Again, Guillain-Barré syndrome, similar to MERS, which is inflammation of the nerve that can lead to paralysis. ADEM, which is inflammation in the brain and the spinal cord, as well as seizures. So there's all of these things that have been reported, and unfortunately, we are starting to see some of these even closer locally. Well, when are we seeing these things? And in truth, we're seeing them throughout the course of the infection. So interestingly, a number of these can be seen even prior to developing other symptoms. So before you get the cough and fever, we're seeing people, for example, presenting with stroke who otherwise look well. And only when you test them do you realize that they are positive for COVID-19. We can also see these troubles extending beyond the virus. So even several weeks after the virus is confirmed, we can see some of these kind of post-viral inflammatory complications. And so as you can see here, throughout the course of the COVID-19 infection and even beyond, we are seeing neurologic complications. So let's talk a little bit more though about those. Those are the kind of concerning complications that make the news, of course. And like we were talking about stroke, it's interesting because there's in general, we're finding that people with COVID are at increased risk of developing clots throughout their body. And it's really when it presents with a clot in the brain that we diagnose a stroke, that people are getting clots in their legs and in their lungs. And there's something about the virus that is causing people to clot more. In terms of encephalitis, which ultimately is one of the greatest fears, so whether or not a person could actually develop infection of the brain itself, well, thankfully, that seems to be a lot more rare. So there are case reports of patients developing infection of the brain, but really they're just case reports, and it's not something we're seeing a lot of. What we are seeing a little bit more of, though, are inflammatory complications. And so sometimes the immune system can get triggered by a virus and then cause an autoimmune attack on various parts of the nervous system. So with Guillain-Barré syndrome or GBS, that's an autoimmune attack on the nerves. With ADEM, an autoimmune attack on the brain and spinal cord. And then finally with myelitis, autoimmune attack on just the spinal cord. So these are scary complications. I was saying they're definitely more rare. The trouble is when you have a rare complication in a common virus, we are actually going to see significant numbers of them. So for example, if you're told that you have a 1 in 1,000 chance of getting something, well, of course you think, that's not too bad, it's unlikely. But in Alberta already, we've had 480,000 people infected with the virus. And so if you have a 1 in 1,000 chance of getting something, suddenly that's 480 people that can have a rare disease. And so these numbers are significant. The other trouble with increasing numbers is that, as you can imagine, patients with neurologic complications require greater care. Their medical care is complicated and it requires expertise. And so when the medical system is already stretched thin by many other patients, it's sometimes a little bit more difficult to provide that care to these patients. Finally, again, a rare complication that happens in a handful of patients is very meaningful because unfortunately these complications can have quite bad long-term outcomes, and so we need to take them very seriously. That brings us to the question of what might persist. So this is kind of starting to talk about what we don't entirely know and what we're learning more of. And so we know that there's kind of common and uncommon complications that happen at the time of the virus itself. But what we don't know and what we're trying to learn more about is whether or not these problems linger. And so this group in South America did this study where they looked at 50 patients who lost their sense of smell during their COVID infection. And they assessed these patients at least 3 weeks after recovery. And many of them, in fact, it was many more weeks after recovery. And what they were able to show is that about a third of patients still had troubles with their smell, even after recovery. When they tested these patients, so there's ways to actually test smell and see how well a person can pick up different smells, they actually found that more than half of the patients still had some impairment in their ability to smell. One of these 50 patients, in fact, still hadn't recovered at all and still had complete lack of smell. And you can imagine that losing your sense of smell would have a large impact on your quality of life. One of the more kind of scary things that is coming up in the media a lot more is whether or not COVID infection can be associated with thinking changes or cognitive dysfunction. And this is something that's particularly concerning because it appears as that there's a portion of patients who may have thinking problems even without significant infection. A lot of the earlier studies, like the two that I described here, were done on sicker patients. So early on, we recognized that sicker patients did have troubles with their thinking. So this French study that looked at patients when they were discharged was able to show that, again, about a third had thinking troubles at the time of discharge. And then there was another study that was done a little bit later, so longer than just at discharge, but 30 days after, that actually demonstrated that, again, a third of patients were in the ICU, so quite sick, had ongoing thinking troubles. The thing is, though, that it doesn't appear as though if you don't have significant infection, that you're necessarily spared from this complication. And so there's been a lot of talking about how young people are really spared some of the worst parts of this disease. But it's appearing as though they may not be completely spared from some of these longer term effects. There's this one study that looked at university students who had COVID and who didn't have significant disease, so who weren't admitted to hospital. And as many as 50% of them had ongoing symptoms, so troubles with smell, fatigue, troubles with increased headaches, and then even non-neurologic symptoms like troubles with exercise tolerance, shortness of breath, and chest pains. Other studies have also been done on these populations, and they show higher levels of depression as well as impaired concentration, even after having a relatively mild symptom. So what is this post-COVID neurologic syndrome? Again, it's not completely surprising that this is developing because, in fact, SARS and MERS, there's a proportion of patients that were found to have, again, prolonged neurologic symptoms even after recovery. This post-COVID syndrome is emerging, describes things like muscle pains, headache, dizziness, and loss of sense of smell, this brain fog or trouble with concentration and attention, mood issues and sleep issues that again persist even after non-severe infection. So more questions remain around this. And so we don't know how many people will truly suffer from this. Some of the studies that are coming out now suggest a relatively high number of patients, but there's some bias in that because these are the patients that are presenting for studies. So it may be that a smaller proportion of patients will suffer from this, but we have yet to know exactly how many. We also don't know how long it's going to last. Ultimately, obviously, lots of these patients are being seen quite shortly after their infection, really only just months. So maybe this will be something that bothers people for months and then it'll settle. If it does last longer, though, it'll be really important to figure out what drives or causes these symptoms, because ultimately, it's knowing what drives or causes these symptoms that will lead to some treatments, which of course we don't have at this stage. So what are some takeaway points from this? Well, like I mentioned, there's some common neurologic symptoms that are associated with milder infection like headache, loss of sense of smell, and muscle injury, and they appear to be, again, quite common. There are some more rare complications that can happen that, even though they're rare, we are seeing a decent number of because of the sheer number of people who are developing this infection. And finally, even in patients who don't have significant infection, we're starting to find out that there may be some longer lasting effects that can really affect people over the long term, and may, if it's happening in a significant number of people, really affect our public health.
So I think, both of the presenters so far have really shown how COVID can impact the nervous system. And included that were some psychiatric symptoms that were mentioned. But it's important to remember that of course, COVID-19 isn't occurring in a vacuum. This is occurring in a world where social isolation has become part of our daily life. And so our next two speakers, I think, will allude to those factors as well. So up next, we have Dr. Catherine Aitchison, who's a psychiatrist and a geneticist by training, and a professor in the departments of psychiatry and medical genetics at the University of Alberta. She works with the Neuroscience and Mental Health Institute as its Associate Director for Mental Health and is Director of Alberta Health Services Edmonton Mood and Anxiety Disorders Program, where she and her colleagues aim to work collaboratively with patients to provide patient-centered care. In her research, she leads the Precision Addiction and Mental Health Lab, which focuses on precision health for mental health. And tonight, she's going to talk about COVID-19 and mental health. How can we protect the vulnerable?
Thank you very much, Ian. So in this first slide, it's about some research on the rates of anxiety in individuals using a supportive text messaging service who responded to a survey. The text messaging service was called Text for Mood, and it's a healthcare innovation created by Dr. Vincent Agyapong, an NMHI member and also director of Alberta Health Services Division of Community Psychiatry. At the first message, respondents were invited to complete an online survey that screened for anxiety using the Generalized Anxiety Disorder 7-item rating scale. Data from about 32,000 people, most of whom were living in Alberta, using this service in its first week between March 23rd and March 30th, 2020, were analysed. 45% reported moderate to severe anxiety. Those at increased risk of such were gender diverse, women, less than or equal to 25 years of age, Caucasian, otherwise known as white, unemployed, married or with a partner, in rental or other accommodation. While there are limitations to this study, including the response rate, which was 20%, and how representative the group responding were of the general Alberta population. Nonetheless, there have been similar findings in other surveys. For example, in Toronto, a survey reported that young people, women, and those who had lost their jobs were more likely to have anxiety or depression in the pandemic. This paper reports an analysis of the same dataset by Dr. Agyapong's group, in which he looked at obsessive compulsive symptoms, such as very frequent hand washing. Such symptoms were screened for using 2 questions from the Brief Obsessive Compulsive Scale, adapted for the pandemic context. The first question was, I am worried about dirt, germs, and viruses. For example, fear of getting germs from touching door handles, shaking hands, sitting in certain chairs or seats, or fear of getting COVID. The second question was, I wash my hands very often or in a special way to be sure I am not dirty or contaminated. 60% answered yes to question 1. 50% answered yes to question 2, in fact more than 50%. And about 85% scored moderate to high in terms of stress levels on the perceived stress scale. 40% screened positive for depression on the Patient Health Questionnaire 9-item. And those more likely to answer yes to question 1, that is, to express worry related to contamination with dirt, germs, and viruses, were men at least 60 years of age, Caucasian or white, with post-secondary education, retired, widowed, or living in their own homes. In this next slide, we see data from Mental Health Research Canada, which has conducted 3 polls during the pandemic on about 2,000 adult Canadians in April, August, and November. In April, the proportion reporting anxiety was high at 22%, while depression was 16%. Levels of anxiety and depression were slightly lower in August and slightly higher again in November. More than half of those reporting anxiety or depression had a moderate to severe illness. Prescription medication was the most common treatment, and 1/4 were receiving therapy administered by a professional. In April, 1 out of 3, that is 33% of people, reported that the fear that they might catch COVID was having a negative impact on their mental health, which rose to 40% in August and November. 50% reported that concern for their family was having a negative impact on their mental health. And you can see in the slide the factors associated with a negative impact. Of note, recent job loss here, 30% reported that was very negative, 37%. Among frontline workers, levels of anxiety and depression since the onset of the pandemic are higher at 29% and 24% respectively. 1/4 of Canadians who consume alcohol say their consumption has increased since the COVID-19 outbreak. This has remained steady since the first poll. However, the proportion who have been taking cannabis has gone up in the 3rd poll, as you can see here at 34%. These figures are consistent with data from the Canadian Centre on Substance Use and Addiction from a survey of about 1,000 Canadians conducted early on in the pandemic in April. 25% of Canadians aged 35 to 54 were drinking more while at home due to the pandemic. The main factors being lack of regular schedule, stress, and boredom. For the majority, 90%, the consumption of cannabis had remained the same. This figure shows the predicted opioid overdose deaths in Canada during the pandemic based on 3 scenarios. In scenario 3, in red, public health measures prevent only 20% of deaths, and as you can see, we would get a very large rise, unfortunately, in deaths. In scenario 2, in green, public health measures prevent 40% of deaths. And in this one, scenario 1, only 60% of deaths are prevented. In fact, sadly, there was an increase in opioid-related deaths in Ontario, Alberta, and British Columbia during the first 15 weeks of the pandemic compared to the previous 15 weeks, with relevant factors including substance use as a coping mechanism and lack of access to services, for example, supervised consumption sites. This slide is about work conducted by Dr. Suzette Brameau-Phillips from the Heroes in Mind Advocacy and Research Consortium at the Faculty of Rehabilitation Medicine, University of Alberta, also with AHS, and she is an NMHI member too. In this review paper, she outlines virtual trauma-focused therapy as a potential treatment for military members, public safety personnel with post-traumatic stress injury. The review states that the incidence of post-traumatic stress injury among military members, veterans, and public safety personnel is high. Public safety personnel, including paramedics, police, fire, or correctional officers. It varies though. Within military and veteran populations globally, the PTSD, post-traumatic stress disorder, prevalence is persistent, complex, and may increase over time. PTSD was reported as 16% in 2016 in Canada for veterans. And global post-traumatic stress injury studies among public safety personnel also show high rates, severity, and complexity compared to the general population. The prevalence of PTSI among public safety personnel pre-pandemic in 2018 in Canada, as outlined in her review, was 35% in police, 35% in firefighters, 50% in RCMP, and 50% in paramedics. So has this been reflected in distress calls, for example? Well, to some extent, yes. The Canadian Mental Health Association Edmonton region reports regarding their distress line that although calls taken have not increased overall, they have seen spikes at certain times. They have seen an increase in the complexity of calls as indicated by longer call times, an increase in suicide-related calls, sadly, an increase in mental health concern-related calls, and as for the Edmonton 211 general helpline, overall volumes have increased, and there have been spikes in calls over the course of the pandemic, with increases each time there is a new government announcement or when resources are rapidly changing. In this slide, you can see what I have said so far about PTSD, anxiety, and mood disorders such as depression in a graph, where you can see the frequency in the Albertan population. The general population frequency is about 1.7%, but it's up to 50% in the high-risk groups, such as those that I outlined PTSD in, i.e. the public safety personnel. It's also high in those with other risk groups, but these are the base rates for anxiety and mood disorders at 6 to 8% with anxiety and 10 to 12% with mood disorders. Here you can see the rates during the pandemic, and these data come from not only Alberta but also beyond, where depression is high now at up to 44% and self-reported anxiety is up to 47%. PTSD at least 50%. There are some reports that, for example, in RCMP, the rates are now over 50%. And so if the upper limit for each of these is close to 50% or more than perhaps, then that works out as 1 in 2. And if that's 1 in 2, that means there's a 50% chance that somebody might have one of these conditions. It's like throwing a dice. You may or may not have it. And if it's like that, then surely anybody with one of these needs to realize that they're not alone in their struggles, and there really is no reason for stigma. No reason for stigmatizing oneself, and no reason for stigmatizing anybody else. This slide from the website on the lower right of the graph outlines how, although some people may get PTSD, depression, anxiety, and very high levels of distress, most people do manage to develop resilience in the face of trauma and even to achieve post-traumatic growth. Who are those who are particularly vulnerable? Those in the lower blue bit of the graph that I just showed. Those who are more vulnerable to physical, economic, and social impacts of the pandemic, such as frontline workers as outlined, COVID-19 survivors, those in the LGBTQ2S+ communities, Black and minority ethnic people who are more likely to suffer from the effects or even to die, sadly, from COVID-19. Indigenous people may be at increased risk owing to disparities in the provision of health care and other things such as police and fire services, those in abusive relationships, immigrants, refugees, international students, those already in poverty, the homeless, those with disabilities or pre-existing mental illness or dementia, and those in prison. So here's this graph again. How can we help people to achieve post-traumatic growth? Well, this graph from the website on the lower right of the slide shows that there are 5 domains of post-traumatic growth. Firstly, personal strength. Secondly, close relationships. Thirdly, greater appreciation for life. Fourthly, new possibilities. And finally, spiritual development. Each of these start with change. Change, 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 change. See? That's the starting point for post-traumatic growth. You have to be willing to change, to grow. And how do you cope or start the journey if you're in the blue zone of the graph that I showed? Well, you start with a first self-assessment. You take the first brave step to find out whether you really do have depression, anxiety, PTSD, or another mental health condition. This website was set up by the federal government. In October, the federal government pledged 66 million Canadian dollars over 2 years to support community-based organizations responding to substance use issues, including help in providing frontline services. And a further 93 million to help improve Canadian wellness, 50 million to bolster distress centers, and 43 million to provide further support on the Wellness Together website pictured here and the resources it offers. What about resources locally? Well, Alberta Health Services has a lot of resources for anybody struggling. I already mentioned the Text for Hope program. There's also Together All, and there's virtual stress management workshops that you can sign up for. There are many different resources for people with many different specific needs, so please check them out. These links will all be made available to participants after this session. And if you are in acute distress, please get help. If it's really urgent, of course, dial 911. If you need some health advice, try 811. And there are various other helplines that you may try, and a crisis text line, as well as a crisis phone number. And for those struggling with alcohol and cannabis use, please tell them that excessive or high-risk cannabis and alcohol use can weaken your immune system and make you more susceptible to COVID and other illnesses. And maybe that will be enough to help them try and change their behavior. Please direct them to Canada's lower risk cannabis use guidelines and other resources, such as those on coping with stress, anxiety, and substance use in the pandemic. And how else do we help people? Well, there's virtual healthcare. There's been a rapid uptake in virtual healthcare during the pandemic. And this has been supported by changes in policy, financing, and delivery. We need to reduce barriers for virtual care, though, including any barriers for those with disabilities and any insurance coverage barriers. So AHS has introduced reimbursement codes for the provision of virtual care. And there are fancy things also available. So here we see Dr. Bramo Phillips's virtual reality facility, where she is looking at how this may help those with PTSD and PTSI. And there's also transcranial magnetic stimulation, which is available for treatment-resistant depression, anxiety, and most recently, it's become available in a clinic, the Envision Mind Care Center for treatment-resistant OCD. There's also psychology, and there are both AHS psychology provisions as well as private clinics. So this is a segue into Dr. Silverstone's talk about resiliency. And I'll just mention in brief that it helps to recognize moral distress, to maintain or reinstate healthy habits, to cultivate humility, to recognize any emotional upregulation and deal with it. And if you find yourself taking pleasure at somebody else's suffering, beware, that really means that you've got unhealed trauma and you need to look at it and cultivate your calling and self-compassion. That's it, thanks.
Thank you, Catherine, and that does segue nicely into our next speaker. So Dr. Peter Silverstone is our final speaker of the evening. He asked for a brief introduction so that he could get started. And since he is a professor in psychiatry and currently the interim chair in psychiatry, which makes him my boss, I will comply. And I will let him educate us on what we can all do to protect our mental health during the pandemic. So Peter, over to you.
So thank you for coming today. And I know that there's a lot of really interesting work that was presented by my colleagues, but I'm not going to show you tons of slides and data. I'm going to talk to you about what the impacts are, why they occur, and how hopefully we can look at treating them. But I'm not going to sugarcoat this. I am going to show one visual, and that visual comes from my Twitter feed, because what I really want to talk about is what do we know, what do we expect, and what are we actually seeing in the mental health region. And I'm going to try and cover all of that in about 15 minutes, which was my allotted time. So I apologize in advance. I'm also English, and I speak fast when I'm excited. So if you suddenly say, hey, what's going on? I'm sorry, I'll do my best. So what do we know? When we look at this particular pandemic, we have to remember that it isn't just one thing. We have COVID-19, but it is not occurring by itself, because of course we also have the economic catastrophe and crisis that we have in this province. And therefore disentangling the impact means we have to look at the economic impacts and the COVID-19 impacts. And of course, those two merge as well. And so what we do is we take the data from what we learned from previous recessions, what we know about that, and also what we've learned from this. And one of the most extraordinary and remarkable things is the way that the entire scientific community has refocused on COVID-19 and allowed us to come to some pretty interesting conclusions, which weren't always as expected. And so let me just cover some of the areas, and I will end up talking a bit about resiliency and what we can do, but some of the areas: depression and anxiety. I think it's pretty obvious that rates increased. There is much more depression and much more anxiety in the community. But what we don't know is what happens to that. Is it long lasting? We did a really interesting study a few years ago with some colleagues. And what we found was that, at least in family practice, a lot of the depression and anxiety was quite severe, but it disappeared after the stress. So we can be hopeful that some will disappear. Not all of it, but some of the depression and anxiety will disappear. What about suicide rates? Well, when the problem started, when COVID started, I did a thread really from Twitter to look at what I predicted what would happen based upon existing evidence. And this is the thread back from March. And so let's look through this and see, was I actually right? Was I accurate? Can we predict? And what's happened since? So when we were looking, this is back in March, so very early on, we were aware that there would be longer term mental health impacts. right at the beginning, this was obvious, and I was using a word such as tsunami of mental health problems. And I've been able to read some of the questions that have come up during the sessions. And one of the questions is, what do we do? But this tsunami of problems is very real. And at the time, I used that word no sugar coating because I did expect some poor outcomes, and I wish that wasn't the case. So let's see what happens. There was a lot of science about what we did and where we came from. Again, this is back in March. We did expect depression and anxiety rates would increase. They have done in every economic depression. There was some suggestions that it varied depending upon age. And some of you may recall at the beginning, we were concerned about seniors, we were concerned about young people who had differential rates, and there does seem to be there. One of the things that really concerned us, suicide rates. We know, or at least seemed to know, that suicide rates increased during recessions. What would happen here? And I'm very pleased, there's some colleagues who have tracked this very carefully. I'm very pleased to say we have not seen suicide rates increase. I think that was one of the things that many of us were very, very concerned about. There have been increased deaths from opioids, and we can talk potentially about why. But thankfully, one of our tremendous fears was that suicide rates would go up. And that's counterintuitive. We've been locked away, been isolated, we've got increasing depression and anxiety. As we've seen, this increasing alcohol and drug use. That was also on my Twitter thread. And yet, thankfully, suicide rates haven't gone up. Alcohol and drug use, cannabis use, has done. And what's interesting is, again, you could almost predict the opposite, because in a recession, when people are particularly reducing their available amount of money, cash, alcohol and drug use rates tend to go down. People just don't have the money. But we didn't see that. In fact, as Dr. Aitchison clearly showed, rates went up, and that's there. It's not minimizing the impacts of isolation. People have coped in different ways. We know that isolation does lead to mental health issues, and no question of that, and we've got some good neuroscience to show what happens. But it is recoverable. There was a question earlier about isolation in seniors and cognition, and there's no question that there are longer term effects from isolation in seniors. They can become more disruptive, they can lose their bearings, and they may not get them back. But for most people, it is recoverable, we think. And therefore, when we look at the psychological effects, I'm not trying to minimize them, but when we look at the psychological effects, and we know that a vaccine is coming in 3 to 4 months, the question is, will those negative problems, whether it's the depression rates or the anxiety rates or the use of alcohol or drug rates, translate into longer term problems? And the answer is we don't really know on that. We did some interesting work, particularly led by myself, or I was involved with many colleagues at the U of A who studied the Fort McMurray fires. And the bad news from that is that those who experience trauma, early we saw rates of PTSD going up, those who experience trauma often had long-term impact. We've got data now going out 3 years. So there is a real risk. And we've got the trauma both from the change in role and change of life. We've got the grief from the loss, those people who have lost loved ones. And of course, we've also got the trauma from those involved with having to address this terrible set of illnesses where people are coming in, they're not being able to help and having to deal with large numbers of very sick people you can't deal with, and sadly increased casualties. So the PTSD impacts are significant. There's the direct ones and the indirect ones. There's the grief and loss. And as we heard at the beginning, there is also, of course, long COVID, all of this tremendous mental health problems that seems like it's long lasting. Because COVID is a disease of many organs of the body, including neurological. And I think that is something we need to recognize. I think that some of these mental health symptoms, the fatigue, the depression, the lack of energy and drive, can be very long lasting for some people who are called long haulers. And I know some of you are in the audience because some of you wrote questions. So this is a real issue for many people, very understandably. And if you were to ask me where I would be putting dollars for treatment, for specifically post-COVID, it would be focusing on those long haulers, because I think there'll be many of them. And I think we're beginning to understand the reasons for them, which look like it might be an autoimmune response induced, sometimes even in mild cases. There's a lot of people who had mild cases of COVID, but the autoimmune response, the immunological response, has led to many other problems. So I think we have short-term and we have long-term mental health problems, and they are real and they are significant. Many of you came today, though, not just to hear the bad news, which I think you're very aware of, but to know what can we do. And as I look at the time, I'm just going to try and sum this up, because I do want to give a decent opportunity for questions. There are a number of things that can help, but I'm going to tell you about 5. And I do a lot of public work, and I always come back to these 5 things. Please consider them, because we know, because of the neuroscience and the evidence, that the more things you do, the better. Number 1, top of my list, is exercise. I think the evidence for exercise helping mental health has become overwhelming. And you might say, well, I'm exercising, in which case I'd say exercise more, somewhat flippantly. If you're not doing anything, do a minute a day today, and then tomorrow, 2 minutes a day, and then 3 minutes a day. Within 2 weeks, you'll have added about 15 minutes of exercise a day. That'll get you going. Try and do things that make you sweat. That seems to be better at releasing those chemicals in the brain that help, endorphins, enkephalins, and other brain chemicals. So exercise is really important. Try and aim between 15 and 30 minutes a day. And it's much better to do daily exercise than it is to do intermittent exercise. If you think about release of the important neurotransmitters that we're looking for, it goes up and then down. And if you're doing some all the day, every day, often you can have them. So exercise is 1. Number 2, positives. Positives in your life will help. Every day when you sit down for dinner, ask those around you, or if you're doing Zoom calls, ask everybody you interact with or co-workers, tell me one positive thing that you have seen or experienced or enjoyed today. Just one, because it's important for you to hear positives and, of course, to give positives back. So those are important. Mindfulness can be really helpful. There's a number of really good mindfulness exercises that help. Even short periods of mindfulness, 15, 30, 45 seconds or a minute of focusing on other things can be really good. A lot of people recommend an exercise, I Spy with my little eye. And then when you solve the problem, you say, okay, now I'm going to do a quick mindfulness exercise to really ground you. That's useful. There's a number of cognitive behavior therapy techniques, CBT. We actually run programs for free, Center for Online Mental Health Support. We've taken a bit of a breather, but there are a number of really good cognitive programs that help. And prioritizing and setting realistic goals can be really useful. One of the aspects of CBT that can be very helpful is at the end of each night, this is number 5, think, okay, here are my 1 or 2 SMART goals. Those are goals I can achieve that are time limited. So tomorrow I'm going to spend 15 minutes organizing my spice rack, or I'm going to spend 15 minutes doing a jigsaw puzzle, or I'm going to do something else. And if, like many of us, you're stuck in front of a computer, think 2 of the 20-minute rule. I'm going to study, focus for 20 minutes, then I'm going to take 10 minutes off and do something different, then I'm going to come back for 20 minutes. So in terms of boosting mental health resiliency, these 5 techniques that I've talked about are effective, and the more of them you do, the better. There are other things we can talk about, but I think I was asked to finish 20 minutes early to allow time for questions, and I think I'm reasonably on time. So I do apologize for talking fast, and now I'm going to hand back to Ian and the rest of the panel.
Wonderful. Thank you, Peter, for that talk and for being right on time. So there has been, we're going to go into the question and answer session. I've been scanning through. We have almost 50 questions now, and I've tried to group a few together, and we'll start with those. Panelists, I asked you to turn on your cameras and be ready to participate. If you've looked at the Q&A and you see a question relevant to what I asked, then feel free to work in that information. So my first question, we've had a few questions in the Q&A about long haulers, and it was touched on by a couple of different people. And I guess the question, some of the questions relate to how common are these long-term neurological effects? And then what are the barriers to treatment? So one individual mentioned that sometimes chronic fatigue is not something that's easy to convince their GP that is necessary to treat. Are there recovery centers needed or other kind of specialized care for long haulers to deal with their issues? And what are some of the kind of symptoms that we're seeing in these long haulers? So I will start. Jen, you can go first, and then everybody else can jump in later.
So really good questions. I think it remains to be seen in truth how common this is. I have a kind of a growing post-COVID clinic, and I've been seeing a few of these patients, and it's going to be difficult because I think also the symptoms are quite varied. I'm seeing some patients that seem to have some of these autonomic symptoms like Chris was referring to. So patients have troubles with blood pressure, feel very tired and run down, and it seems to be maybe in keeping with the syndrome called POTS. Other patients have more kind of muscle aches and pains, and so that's probably a different group. And so I think ultimately a collaborative approach is going to be the best way to approach these patients, because I think that it's going to be a myriad of symptoms that might be best kind of dealt with by different people. You know, patients who have more muscle aches and pains and weakness might, be best served by physiotherapists and work really on exercise. Exercise, of course, can be helpful for everybody, as Peter said, but whereas a patient with autonomic symptoms might have to focus on drinking more fluids and eating more salt and potentially using compression stockings. So I think when we characterize these syndromes a little bit more, we'll be able to have a better idea of what we can do to help everyone.
One of the things you've touched upon, which I think is true, which is treatment centers. Multi-specialty clinics is not something we've been good at generally for a variety of reasons, but particularly in this country. I wouldn't even say in this province. Both Catherine and I obviously have UK experience, or if you didn't realize that from our accent, I'm sorry, we didn't make it obvious enough. I'm trying harder now. And you can get multi-specialty clinics more frequently then. And they're very necessary for patients like this who are complex and who present differently. It's hard. And also when you have a set of symptoms that is hard to tie down and you can't measure, it can be a particularly difficult journey for patients. And that's one of the reasons I am most concerned about this group.
Great. So actually on the mental health theme, there's been a couple of questions about telehealth and virtual treatment. So with respect to kind of the remote treatment, some questions about severe mental health concerns and the safety aspects, what can be done about that? And then also, do you think that it's going to become normalized? Like eventually we're going to be able to sit in the same room with other people. Do you think remote therapy is the way of the future? So Catherine, you can start, and Peter, you can add.
Okay, so I did read one of the questions, and it was specifically around whether if it's trauma and other aspects, whether telehealth is equally good as in-person care. And I think the person has a good point, essentially, that yes, in-person care is better, actually, in mental health for many aspects of mental health delivery. And I will say that at the University of Alberta Hospital, people made every effort to continue the outpatient services live in person. And so therapists came in regularly and saw people when they needed to be seen in person, and doctors did too when they were able to do so. With the patients who were being seen virtually, because that was their preference and or they didn't need to be seen in person. So, however, at the moment, of course, virtual care is being encouraged as the routine for safety, public health safety reasons. In regard to something that Ian basically raised, will this become the routine for the future, or will we go back to in-person care? I would say that what this whole experience throughout the world of virtual healthcare delivery has been is it has made people enter this road when they might not have otherwise. And there are some advantages to it. So it can deliver care to remote, rural, etc. communities that might not otherwise have care. And we're blessed here in this province with telehealth that really does extend quite far-reachingly. And then, of course, if you're not comfortable with a video call, you can just have a phone call. Alberta Health Services also covers that. And however, I think that we will also have in-person as well. I think we will have both in parallel. And the ratio between the two, I don't know about that. I can't predict that right now.
So I'm going to echo and disagree slightly, politely, only perhaps because I'm interim chair and I'm very proud of what we do here. We are, most of you wouldn't know, we are actually among the leaders, if not the leaders, in remote mental health care in this province. And there's a number of super initiatives, one of which was mentioned by Catherine, which is the Heroes Group. And in fact, the disagreement is that I think that there will be preferential availability of remote mental health support in the future for a number of reasons. We've done a number of studies here where we've shown that when you take certainly group sessions and you move them online, and we did a couple of different ones before the pandemic and found that the outcome were almost identical. So that you can take much of what you do in person and move it to remote learning. Secondly, when you look at just groups in general, a number of our colleagues, primary care networks and so on, have moved their groups online with what appears to be very similar outcome. I think the literature needs to be said. But just as importantly, and again, to echo Catherine's point, one of the things, necessity is the mother of invention. Many people have come up with new techniques of doing things. So for example, when you're looking at trauma, and we're trying to measure your feedback, there's a technique called EMDR, eye movement desensitization and reprogramming, where I am looking at you and measuring your autonomic response. So you're sitting in the room with me, I'm doing something, you're hooked to a machine so I can measure, various things. Well, one of the most exciting things is I know at the U of A, there's a team looking at doing that remotely. How can we attach things so that via the computer, Bluetooth essentially, I can give you live real-time feedback? It's pretty easy now for pulse. I'm looking for a pulse oximeter. I had one which would go on your finger and you can measure that. You can certainly, Apple Watch will give you your pulse. You can buy a gadget for an Apple Watch that is a heart rate monitor that you can send. So I think our ability to offer meaningful and useful therapy is improved. And last but not least, the reason I am completely optimistic and encouraging e-mental health solutions is because of the scale issue. We have a huge, huge number of people. And as Catherine correctly said, many are remote and rural and don't have access. How do we help them? Do you get people to drive in for an hour and a half or 2 hours for a 20-minute appointment? Or is there some way to support people remotely more effectively and so on? And so I actually don't think that, I think there'll be a transition back, but I think the opportunities raised for mental health and our ability to offer, for example, the kind of treatment program that may be necessary for the patients Jen wants to see, I think the only way we'll be able to do that realistically is by weaving e-mental health into pretty much everything we do in the future. Ask me again in a year though, and I'll be able to tell you more accurately.
Thank you, Peter. So I have a question for a neurologist, but actually before I do that, so Peter, I think people have got their pens ready now, and they were hoping you would repeat the 5 things briefly again so they could write them down.
Okay, 1 is exercise. 2 is a positive thing every day. Ask somebody about a positive. There's actually lots of books on the power of positivity, which might sound a bit hokey, but actually the neuroscience is really interesting about doing that. And exercise, I won't go into it, it's well done. 3 is mindfulness. There's lots of good resources for mindfulness, weaving mindfulness in, practicing it every day, even if it's only for 30 seconds to a minute, try and consciously do that. 4th is cognitive behavior therapy, lots of tools of cognitive behavior therapy. There's free online tools, there's books, there's self-help, there's lots of groups. And a key part of cognitive behavior therapy that I really encourage people to do, and I actually came up with 6, so I'll do the 6th one in a minute. But the 5th one was the scheduling. The night before, think about 1 or 2 things you are going to achieve tomorrow. They should be what we call SMART goals, achievable, time limited, and give yourself a pat on the back when you do them. Don't say tomorrow I'm going to learn Latin, or I'm going to do my taxes or something like that. That's not the purpose. This is small achievable goals that you can succeed at, and they can be doing fun things. And that also brings me to the 6th thing I said, which is if you're in front of a computer, try and do a 20-minute rule, which is 20 minutes focusing and 10 minutes doing something totally different, preferably getting up and down and exercising, but 20 minutes on and 10 minutes off, and then you'll find that you can concentrate a lot better.
Awesome, thank you. So hopefully everybody got that time. Great advice. So my question, so Chris, you can start with this, and then Jen, you can jump in. But then we had a few questions about mild disease. So does the virus have to hit your lungs hard for you to have these neurological symptoms? And then looking at the studies, a lot of them, and I noticed this in my own, kind of studying about this as well, is a lot of them restrict their study to hospital patients. And so with respect to these kind of neurological things, what do we see in mild disease? What do we see in people that don't perhaps make it into the hospital, such as I think youth were mentioned?
Yeah, so I'll start. Jen can weigh in also. We definitely, neurologic symptoms and signs emerge among people who've not been hospitalized, who have relatively mild disease. And it's not necessarily at the time of when people are ill, but actually even there can be a delay of upwards of a month or two. And I think Jen showed that from Tom Solomon's paper in Lancet Neurology, that the neurologic symptoms can be later on. So I think that's a concern. And those symptoms can be pretty substantial. Fatigue, brain fog. And so we don't really understand that. I think that lends a lot of credibility to Jen's thought that this might be an autoimmune process as well, the delayed onset. So something we don't know enough. There are large prospective studies that are being launched. There's one at the NIH, one at the Cleveland Clinic, University of Michigan's got one running as well. So I will have that data probably in the next few months.
Just to add exactly what Chris said, but just to kind of reiterate, even some of the more concerning complications are sometimes in patients without even any significant lung disease. So we're seeing sometimes patients with very significant neurologic troubles like stroke who have no otherwise systemic disease. And so definitely there's that link. And then that one study that I talked about with university students, I mean, you're right that most of the studies are being done on hospitalized patients, but that very specifically was done on non-hospitalized patients and showed that even in that group, that 50% of them had symptoms of post-COVID syndrome. So it doesn't seem to be necessarily related to significant systemic infection.
So we've had some questions about, so I think it was Catherine was talking about OCD and obsessive compulsive disorder and how that's gone up. With things like compulsive hand washing, we've had a couple questions about, well, this is a very stressful world right now. People are very anxious, but not necessarily clinically anxious. So how do you tell, the difference between good hygiene, worrying about your health, and really falling into anxiety or obsessive compulsive type behavior? Catherine,
Sure.
I think
well,
you
the short answer, sure, to that is take the test on that National Canada website that I showed towards the end of my slide set. And the long answer to it is, yes, it's a good point. I also saw somebody asking, isn't hand washing kind of normal? Aren't we supposed to be doing that? Which is right, of course we are. That's why I was a little careful in how I did report that study of Dr. Agyapong's, which was not hospital-based patients, in case anybody wonders. It was 6,000 people just living in Alberta out of a total sample of 30,000. The question in the questionnaire included fear of getting COVID. And of course, that's fairly normal as well and fairly high frequency. So different data sets show a prevalence of about 1/3 to 2/3 of people showing being afraid of getting COVID, perfectly understandably. I mean, when you listen to lectures like what we've heard today, it's not surprising that people don't want to get it. And likewise, hand washing, yes, we're supposed to do according to the public health routines. But if you're hand washing to the extent that your hands are red and raw, then that's a problem, right? It's how much you're doing it, how long you're spending it, whether you're going over and above what is really necessary.
Ian?
Yeah.
There are a number of other questions that I could address very quickly in about 30-second answers. Do you mind if I take the liberty of going through them, because there's about 6 or 7, and just quickly, they're not grouped, they're just individual ones?
Absolutely, go for it.
So one is, are we tracking parasuicides, not suicides? And the answer is yes, but that data will be sometime coming out. We've done studies where we look at that. There is actually a code in Alberta Health, but that trailing data will be 6 to 9 months away. But yes, we should be able to see not just suicides, but parasuicides. And I totally accept they're not always linked. A question, any suggestions to use for brain fog and cognitive impairment? And unfortunately, I don't have any rapid tricks. Jen, I don't know if you do or not, but I know with our chronic fatigue patients, it's one of the key issues that we have. Occasionally, some medications will help a bit, but it is one of those debilitating things that people complain about. I don't have any. Do you or Catherine have any specific clinical tricks?
I see it a lot in the setting of multiple sclerosis, and I tell all my patients to exercise, so I don't have any medical tricks either.
So that's what I tell mine. The trouble is, as someone says, they're a long COVID sufferer, but exercise triggers them, as is typical with chronic fatigue. And I usually say that's why I start off at a minute, not 5 minutes, or even 30 seconds till you can tolerate it. Catherine, I don't know if you have any tricks you have.
Well, just kind of the healthy living things, such as dietary things, you know, simple things like foods that help the circulation, carrots, cucumber, celery, tomatoes, apples. Those can actually help when you've got a bit of brain fog, and other micronutrients. There are various substances. This is kind of really off the record stuff. I'm not a licensed naturopath or anything, but there are various micronutrients and anti-inflammatory natural things that can help.
Another quick question I just wanted to mention, which is someone who has COVID notes that they got and I'll use their words, biological depression. And I did my doctoral thesis in depression in the medically ill. And we know that depression often follows medical illnesses. So those of individuals who've had it will just have higher rates, the same with MIs. And I'm sure, Jen, you see this a lot in your clinic with MS patients as well. Last, there's another question here. Again, I hope you don't mind me taking the liberty and quickly going through these and addressing them. Okay, someone said they quoted a study of heavy alcohol use in specific subgroups, which occurs in these areas. And in fact, in that Twitter thread I showed you, I actually addressed that, and you're right. It does seem that some people who are predisposed to use alcohol will use excessive amounts at times like this. There's another question about opioid deaths, which I alluded to but didn't discuss. It might be that that is a sad, unexpected, unanticipated effect of closing the border. In that what seems to have happened, or at least one explanation for what has happened, is because the border has been closed, less dangerous opiates have not been smuggled as much, so people have substituted more dangerous opiates which are available in smaller volumes, such as carfentanil and fentanyl, and that has led to the increase in opiate deaths. It's certainly a very, very sad, tragic issue. We could talk just the whole thing about that. And last one I'm going to try and dive into, and maybe I'll ask Catherine's view about this, is the effect of light and daylight upon mood and mental health as we're entering into winter time. Is there anything we can do for that?
Well, I think the main thing is vitamin D. So vitamin D, we should all be taking at least 2,000 IU per day in the winter and at least 1,000 IU per day in the summer. Many people will have actually got an increased need for vitamin D because of being inside all of the time since the pandemic. So you might try taking even more than that over these winter months. Vitamin D also helps your immune system as well as your brain, your heart, and a variety of different things in addition to the bones. So that would be my first recommendation, and its effect on mental health might be more than one might guess. So it's really worth trying. The second thing I would say is, yes, sure, light is difficult. There are light therapy boxes that one can buy, but they're fairly expensive. Or, you know, if you get a sunny day, which we do from time to time here, then for goodness sake, take advantage of it. You know, sit in the sun, close your eyes, don't let it damage your eyes, or essentially be careful how you use light, both natural and unnatural, but do try and expose yourself to light to help your mood.
Great, thanks. And thanks, Peter. That was great because there's so many questions that it's hard to get to them all. I am going to group another few. So, and actually this, I'll start with, you know, Jen or Chris, you can go first, and then Peter and Kathleen, you can go after, because there's a question about comorbidities. And so specifically, it's been asked about what COVID-19 might mean for a person with MS. Developmental disabilities were mentioned, whether or not, you know, if there was any kind of data there. So neurological concerns effectively, and how that might affect your outcome with COVID-19 if they're pre-existing. And I think we could extend it to mental health as well. And I know you talked about those who already have, you know, mental health conditions, but if you want to elaborate that on all any comorbidities that would be important to consider, and potentially what we can do about it.
So in terms of patients with specific neurologic diseases like multiple sclerosis, thankfully we haven't shown that patients with MS who contract the virus do any worse. They're not more likely to contract the virus in the first place. And thankfully, it doesn't appear as though the virus is, causing their MS to worsen. So really there hasn't been much data to demonstrate any of those things. Of course, if you're on some of the medications, there might be some extra things we need to think about, but that's something you can for sure talk to with your MS neurologist. In terms of other types of disabilities, I suppose it affects exactly what a person is like physically. If a person's disability is such that it affects, for example, their lungs, and they might have some restrictive issues with their lungs, I would imagine that could lead to increased troubles with the virus. But having a neurologic disease in general doesn't increase your risk, unless, of course, that neurologic disease is associated with age, because age, I think, is probably the comorbidity, if you want to call it that drives your risk with the virus the most.
There are some case reports of people in which COVID-19 actually uncovered unsuspected neurologic disease. I can think of a couple. And the other issues, I think people who already have pre-existing cognitive impairment, people who have Alzheimer's disease, they may not be as quick to report their early symptoms, and if there's any that may limit or delay treatment. Getting into comorbidities remain an ongoing and uncertain issue that we need to stand to at this stage.
Catherine or Peter, anything to add on that topic?
I'm always happy to add things in. I am also aware that we've gone over time and that people may wish to go, so I'll keep my answers very quiet. It's sadly common. I mean, the reality of this is that when we look at mental health issues, comorbidity is something we live with all the time. The brain is a complex organ, and you can have symptoms presenting in many ways for many reasons, whether it's migraine headaches or whether we're talking about tiredness or brain fog or low mood. Many of these things overlap, and it's hard to discern them. And one of the problems for patients, and I'm sure we'll be seeing lots more of this. I work primarily with family practice clinics, by the way, is where I see most of my patients, and is that they have mixed symptoms. They don't come in with, here's my depressive symptoms or here's my anxiety. It's this mix, and a lot of the mix is physical issues. And I really believe, and I'm very concerned, that we will be seeing more and more patients who come in who have had COVID, and now they have problems. And there will be some physical problems, and there'll be some cognitive problems, and there'll be some emotional problems and some anxiety problems, all mixed in, and then teasing apart what is actually post-COVID. And I think that will be a real component. But also you've got the anxiety linked to this, you've got all of the changes in life, you've got the weakness, you've got the tiredness. And so I think comorbidities of both medical and mental health will be quite profound, and we'll be dealing with it for many years.
Thanks. Yeah, so as noted, we are over time, and our speakers have to leave soon. I'm going to ask one more because there were several questions right at the start about the stroke phenotype, or the types of strokes that we're seeing. So what types of stroke are we seeing, and are men or women more affected? And what can you tell us about that, the stroke?
So a lot of the early studies showed primarily embolic strokes. So what was concerning early on was that in patients who otherwise didn't seem to have very many stroke risk factors, so younger patients who were presenting with kind of clot strokes in big vessels that caused a great big stroke in the brain. So kind of your ischemic or blood, not getting to part of the brain as opposed to the hemorrhage or the bleeding in the brain. Like Chris showed, though, there's also a proportion of patients who seem to have these what's called microhemorrhages, so tiny little bleeds throughout the brain. So it may be that there's a whole bunch of different kind of types of strokes, some that are related to more systemic or body issues that lead to kind of your more classic strokes where it's a loss of blood flow, and then other types of strokes that may be related to other things going on, inflammation and issues in the brain as well.
All right. Well, I think it is 8:10. We've gone 10 minutes over, so I think we'll stop there. Thank you very much to all the speakers for joining us today. It was really informative, something that's obviously that we're all thinking about, and I think you provided a ton of information. So with that, we'll close the evening. Thanks again, everybody. Have a great rest of your evening.